Hello, and welcome to the Duke Endocrinology Conference. I'm Diana McNeill, Professor of Medicine at Duke University Medical Center. We are glad you have joined us. Today's program is titled Cardiovascular Risk Assessment and Prevention in the Asymptomatic Diabetic Patient. And our distinguished guest is Michael Blazing, Associate Professor of Medicine at the Duke Heart Center in Durham, North Carolina. Mike, thanks so much for joining us.
Thank you for having me. Appreciate it.
So, Mike, what can you tell us about how to assess cardiovascular risk in the asymptomatic patient with diabetes?
That it's a job that nobody desires to really have because there is no right answer. The good news is there's no wrong answer either. There are certain approaches, and what I'm going to go through today is tell you how I approach this and how I try and take data that's done on groups of people and then move the data down to the individual. And I think that's the art of medicine that still exists, and that's what we still have to teach people.
And as we start talking about this, and so many of our listeners are primary care providers, what you're going to tell us doesn't necessarily have to be done by a cardiologist.
It doesn't. What the gatekeeper from a primary care physician can be is what is appropriate for my patient with regards to what can be done to my patient. What can they tolerate?
Okay.
So if I'm 55 years old and I've had diabetes for 10 years versus I'm 85 years old and have had diabetes for 10 years and I think you might have coronary disease and I think you might need a bypass surgery, I think maybe the 85-year-old may not need it and the 55-year-old may benefit from it.
Right.
That's a decision best made by people who know the patient,
That's
not people who's going to do a consult.
Okay.
And that's where the gatekeeper really helps. And that's where the gatekeeper can have the conversation and say, look, you're not having symptoms. You may have this risk. Do we really want to open Pandora's box?
Okay.
Or do we leave it closed? And a lot depends on how active that individual is, how much time you think they have left, because it's not clear always that more is better.
Okay.
And that's what we're going to talk about.
So you're going to give us guidelines to make that decision?
Yes,
okay.
I am.
Good.
Okay. So what we'll start with is really kind of defining what the problem is. And the problem with diabetics is twofold. One, diabetics die of vascular disease. They don't die of diabetes anymore. They tend to die of cardiovascular problems, strokes, heart attacks, peripheral vascular disease that is large. Small vessel disease, preventable if you're really aggressive and take good care of managing the sugar.
Okay.
It's not clear that managing the sugar is going to help the macrovascular disease yet.
And you know that was heresy to the endocrinology group initially, but we've come around. So.
Related, my belief, but not causal, and that's the big issue.
Okay.
The other issue, again, is that the pretest probability, or when I see a diabetic who walks in versus I see somebody who's their twin who's not a diabetic, I know that the individual who has the diabetic, they're more likely to have coronary disease. So I know they're going to have it. The question is it going to lead to the demise? Maybe it will. My goal is to make it lead to their demise when they're old. My definition of old is 96.
Good.
Okay?
All right.
So if I can get people there and then have to make the decision, then it's a win-win situation. And that's kind of what my approach is aimed at.
We always tell everybody that with diabetes that it is a cardiac risk equivalent disease, and so that we need to treat them as if they've already had. Is that something you...
I turn it a little bit, and what I turn it in is based on this. And it's, again, to me, when I try and think a little bit pathophysiologically, like they used to teach us in medical school back when you and I were in medical school,
That's right.
It's not clear what causes the association between diabetes and coronary disease or cardiovascular disease in general. No doubt about the association. It's not the sugar that's the cause, as we talked about.
Right.
Okay, but to me, what it is the following. When you get diabetes or prediabetes, okay, so the metabolic syndrome is simply, to me, on the spectrum associated with diabetes. What that does is make your vasculature much more susceptible to the ravages of aging quickly, okay? Or the ravages of hypercholesterolemia, or the ravages of hypertension, or the ravages of smoking, heaviness, whatever the metabolic derangement is you're going to have. What diabetes does is make you much more susceptible to the injury from that derangement, okay? So if that's the case, what I have to do is make sure that when I'm treating you, I'm more aggressive in doing prevention in the diabetic than I am the non-diabetic.
Okay.
And that's the approach I try and take.
All right.
Okay? This sensitization makes individuals present earlier with disease, often makes them present with more disease.
All right.
Okay? But it doesn't mean you can't at any point in time start the prevention necessary to stop it or at least prevent progression of it. And I think those are the keys. I think the key in this population or in any population you're looking at prevention is to try and explain it to individuals so they understand it. And I've come up with an analogy that I use that at least makes it easier for me to understand. That analogy I'm going to show in the next couple of slides.
All right.
So first of all of us most of us I should say, not all of us necessarily, in America have this kind of problem going on with our vasculature. As you can see, there's some cells there called the endothelium. They're more or less in purple. The red is the bloodstream. The dark blue area is what's called the subendothelial space.
Okay.
Ideally, there should be no space there. When you're born, there is no space there. There's the endothelium. It sits right on top of the basement membrane, and there's a direct line of signaling between the controller cells, the endothelium, and the smooth muscle cells.
All right.
Okay? As we age, something, we don't know exactly what, and that's the key, something allows material to start depositing in that potential space between the endothelium and the basement membrane. That material is lipid for the most part.
Okay.
Then the lipid incites a response from the immune system, which is where the macrophages come in.
Okay.
That response then leads fibroblasts to start coming in. That's where the fibrous cap comes in. Okay?
Right.
And now you have a balance between repair, which is the fibrous cap, and degradation, which is the inflammation. And essentially the way I've looked at this, two ways you can look at it. The way I prefer to call about it is a blister and a callus.
Right.
The other way is like a pimple and one that breaks. And
right.
The pimple works for inflammation, but people don't like to talk about
No,
pimples, so I usually talk about blister and a callus.
Before you switch that slide, Mike, one of the things I think a lot of our listeners may be thinking about is, you said as we age, we develop the blue area, as you said.
Correct.
Is there anything that prevents us from doing that? If we're healthy, should we not eat meat? Should we exercise and run marathons? Is there something that can prevent us from
the individuals who don't have that happen are aboriginal. Okay?
Ah.
All right? So when you're born, your LDL is 40. If you're aboriginal, your LDL stays 40. If you have to work all day for your living and get an adequate living, you get adequate nutrition, you don't die or develop vascular disease. Okay?
All right.
Unfortunately, in the Western society and most other societies, actually, this does not work.
Okay.
What's most interesting is when you take these individuals who have lived this subsistence life for a very long period of time, for many, many generations, and then move them quickly over to a Western-type society and diet, you end up with a epidemic of disease. And we're seeing this in two huge countries.
Okay.
And these two countries are India and China.
Ooh.
Okay? And in India and China, atherosclerosis, atherosclerotic disease, heart attack, stroke, the ravages of hypertension and hyperlipidemia are exploding in the cities.
Okay.
And the reason they're exploding in the cities is because people go from a subsistence diet to one which is a pre-prepared diet.
Right.
Even though it's still vegetarian, say in India, it isn't just the meat. It's the amount of food you get.
Okay.
It's the lack of exercise you do. And when you change, that changes you metabolically. You gain a little bit of weight, especially central weight. That central weight changes you again metabolically to a point where you start accumulating lipid. That lipid, for some reason, very easily transits from the bloodstream into this subendothelial space where it doesn't belong.
And forms this blue area.
And forms this blue area. And what it forms is this, the perilous plaque, as I like to say. And this is the blister.
Okay.
This is when degradation is worse than repair. You get a soft, mushy area. There's very little thin fibrous cap over the top of it. There's a lot of inflammation going on at the border. Again, more like a pimple maybe than a blister.
Okay.
And that's a cap that then or a plaque that then is easy to rupture.
Okay.
And that rupturing is what causes heart attacks. Almost all heart attacks, 70% or more, are not due to things growing shut, but due to the fact that a plaque actually ruptures like a blister ruptures in your hand. Blood sticks to it, that causes the heart attack or the unstable angina.
Okay.
When repair is successful, what happens is you come in, and just like forming a callus, you have a big, thick, fibrous cap that comes in, okay? The lipid pool is actually kind of deactivated in some ways, deactivated, in that cells that go in take the irritating aspects of the lipid out, okay, whatever those might be, oxidation, some people say, other signaling molecules, some people say. The immune cells tend to be much less angry at that point, and you form a callus. And once it's a callus, it's like a callus on your hand. It's stable, it won't bother you, and it does not matter.
Now, does anything ever stick on top of the callus? Because let's say you have an excellent lifestyle and you form this stable plaque, and then all of a sudden you fall off the wagon, if you will. Can you put yourself at increased risk?
So falling off the wagon, just like going out and not having done anything in the yard for a long time, you'll get a blister right on top of your callus.
Ooh, okay.
So the answer is you can change the endothelium from, again, functioning well and trying to signal and working, back to one which is quite dysfunctional, easily leaking, causing new plaque to form right on top of the callus if you fall off the wagon. So prevention is a lifelong issue, not a short-term issue.
Okay, so you have to stay with the program, whether it's lifestyle and or medication.
Correct.
And for our patients with diabetes, looking again at the stable plaque, should we assume that just because of the metabolic derangements that you referred to earlier of diabetes, that almost every patient with diabetes is at risk for development of this, or is there an exception to this?
So the answer is twofold in diabetics.
Okay.
Every diabetic is more susceptible to developing these, at a lower level of risk, So that's the key. So in myself, not diabetic at this point in time, I have a very strong family history, so maybe, but not right now. And right now, if my metabolic is all good, everything looks good, then I would assume that I have a little bit of plaque because I'm American and my diet isn't perfect. But if I took a twin of mine, and gave him diabetes, they'd have a lot more plaque.
I see.
Because my numbers are not perfect.
Okay.
And in order to have prevention, you need perfect numbers for a diabetic, and you need good enough numbers as a non-diabetic.
All right.
It's kind of, it's like the guidelines show you. The guidelines currently say if you're not a high-risk individual, you can have an LDL of 160 and be okay.
Right.
If you're diabetic, you need an LDL of 100 at least and 70 maybe ideally.
Right. Right.
And why is that? It's because your endothelium is much more susceptible to disease, and without that prevention, even with a good LDL of 120, 130, you're going to develop disease faster than the individual at 160 would.
The way you just explained it would be really helpful, I think, for a lot of us that have to try to explain to our patients why they don't feel sick, and we're getting ready to hand them 3 medications.
Right.
So this is a really good way to
So what I say is when they go out in the yard and they put gloves on, they won't get a blister. And they'll do that routinely. That's why they need to take their medicines. Okay. That's why I like the analogy that I use. The risk factors associated with this are multiple, both environmental and heritable. Those include, the environmental factors are diet and exercise primarily. Diet is both what you eat and how much. In this country, more how much than what, to be honest. Because when you become obese, especially centrally obese at all, you end up changing the milieu within your system somehow. We don't completely understand this yet. That really leads the endothelium to be much more leaky, the plaque to be much more easy to form, and your risk to go up dramatically. And the more of these metabolic derangements you have, high triglyceride, low HDL, hypertension, smoking, the more of these things you have, the more likely you are to be developing plaque. It's just like each one is yet another insult that makes it easier and easier and easier for you to develop disease.
So, Mike, let me offer a case just for conversation. So we have a patient who might just come into our office just for routine healthcare maintenance, and we identify centripetal obesity. Blood pressure's okay, fasting blood sugar may be okay or suggestive of pending diabetes. Do we advise these patients that they're going to need to be prophylaxed based on the slide that you're showing us here, which shows so many inputs to cardiovascular risk? I mean, you're telling us that centripetal obesity is an external warning sign.
It absolutely is. It's a marker when the patient walks in that they're at high risk for developing disease, for developing atherosclerosis and or diabetes as time goes on. It's something that needs to be looked at because almost everybody who has that central fat deposition has the metabolic derangements. And it's amazing how little in some ethnic backgrounds it takes. The individuals you really, really have to be wary of are those from South Asia, especially from India on the Asian continent. 5 pounds of fat in the middle will change them from a metabolically neutral individual to a metabolically plaque-forming individual. with nothing. Whereas in a Caucasian, you're really looking at having to reach, in a woman, a waist circumference of 36 inches, in a man 40. In a South Indian, you're looking really at 34 or 36 inches.
Ooh, okay.
So it's very different in how sensitive and how susceptible they are to these ravages.
And before we leave this slide, up there in the corner where it talks about abnormal lipid metabolism, I've been tricked sometime where the lipid profile actually looks okay by numbers. And often when you've seen some of my patients, you've ordered some other labs.
Right.
Would you help us decide when we might need to do that?
So, yeah, that in an asymptomatic patient, the question is a cost-benefit analysis. And I'm going to talk about what this is. So the laboratories we're talking about are what is called LDL subfractionation.
Okay.
And here's the way I explain this, and this is, I think, the easiest way to understand this. And I use a spaghetti analogy. Okay?
A food that we shouldn't be eating on this slide, right?
All depends. If you make it out of olive oil and tomato sauce and turkey, you're probably okay.
Okay, all right.
So if you take a pound of hamburger and put it in one spaghetti sauce, another pound of hamburger and spaghetti sauce.
All right.
One is spaghetti and meatballs, one is spaghetti and meat sauce.
All right.
Okay, so the pound of hamburger represents your LDL level.
All right.
It's the same in both sauces.
Okay.
It's a pound.
Right.
Okay, can be 100 milligrams per deciliter, whatever you want to make it. 100 is a good number.
All right.
In one, you have 1,000,000 particles, spaghetti and meat sauce.
Right.
In the other, you have only 10 particles because it's meatballs.
All right.
What has been very, very well shown is the particle number is much more predictive than the absolute level of LDL.
All right.
And why is that? The reason that is because LDL is not all contained in the same molecule circulating around. It's contained in different molecules.
All right.
Some in LDL itself, some in something called VLDL, some in byproducts of LDL metabolism called IDL. These byproducts are incredibly sticky, incredibly atherogenic. And when you're diabetic, you tend to have an increased number of these byproducts and less of the mature LDL. Mature LDL is like stuff in a truck.
Right.
Okay? It's stuff in a truck, and it goes between the warehouse, the liver, and the house, or the business, which is the cell. That's exactly what it was meant to do.
Okay.
You've got to have delivery of cholesterol to the cell so the cell can make the things it needs to make to function.
Okay.
Okay? What the IDL and the VLDL remnants are like the truck that you sit behind that has the rocks in it that has no cover on it. Right. Everything flying off all the time.
Breaking your windshield.
That's exactly
That's
right. And what they're doing is instead breaking the vasculature. And they're all depositing inside and outside the vasculature rather than in the cell where they belong.
So we don't want meat sauce.
Correct. We want meatballs, and the only way to tell this is to use some sort of advanced lipid testing.
Okay.
Okay? Who deserves this?
And this is an important financial question.
It's a huge financial question because a lipid panel itself is about $20 and this is $200 and often not covered by insurance.
Okay.
So I do the following. If I'm not going to put you on a statin, then I will give you this test to see if you need a statin or not. If I'm going to put you on a statin, I will not order the test. Okay? The reason is once I've placed you on a statin, okay, which is a evidence-based medication for lowering your risk and gotten you down to where I want to get you, and we'll talk about that a little bit later where the level is, then I feel that I don't really need the extra knowledge of what's going on because I've already applied the treatment I'm going to apply to you in an asymptomatic individual.
Okay.
I'm done.
Okay.
If I wanted to use more treatment, then I would add it. If I don't want to use more treatment, I won't.
Okay.
When would I use more treatment? If you had very low HDL, if you had other risks that came up, if you had a very, very strong family history, if you started to develop symptoms or I did something to look at your overall burden of plaque, then we could do that. And that's other testing we'll talk about, again, downstream here a little bit.
Okay.
But I think otherwise, that's it. Now, if I'm trying to make a decision of whether to start you on a statin or not,
right.
Then I'll order it because I'm looking at a $200 test to make in a generic, you're looking at $10 a month, so it's $120 a month, but for life.
For life.
It is really for life. If it's a non-generic, you're looking at $1,000 potentially, depending on what your insurance is like. So it's worth the upfront investment in that kind of situation.
And the last question before we leave this slide is, so we're talking about a patient with diabetes. You're going to tell us that all of those folks should be on statins?
Yes.
And so maybe these tests we just talked about are better for folks that don't already have cardiac risk equivalent disease.
If you don't have diabetes already, or you're trending towards diabetes, or you've just been diagnosed, quote, with diabetes, unquote, or you're kind of on the borderline, I think these tests are reasonable. I think if you're truly diabetic, or you've been diabetic for some time and require medicines for treatment of the glucose derangement associated with it, you should definitely be on a statin. The evidence will support that, and I'll go through some of that evidence.
Okay. I'll never look at meat sauce again. All right.
So, again, what my goal is, and I think you got at this here, and you got at it with the question you just said with regards to diabetic, is really to match the prevention that we're going to do with the individual's risk.
Okay.
And the way I look at doing this is it's a three-step process. Okay. First, what I got to do is use an educated guess to categorize the individual's risk. Okay. And I say educated in that nobody with diabetes is low risk. Okay. So the question is how high a risk are they when they walk in my office? Are they moderate risk, which is a low-risk diabetic? Are they high risk, which is an intermediate risk diabetic? Or are they very high risk, which is a high-risk diabetic? And how do I try and determine that? History is the biggest way to do that, because metabolically they all have at least moderate risk. So the question is how much plaque buildup do they have? How much is what's going on in their vasculature actually limiting in their life that they don't know about? And how much at risk are they for rupturing a plaque that's going to end their life early? 1/3 of all heart attacks that happen, cause sudden death. So 1/3 we don't get a second shot at.
That's an extraordinarily high number.
It's a huge number, and it may be even higher in diabetics. So what you want to do is, how many of these individuals are at risk like that? How many of them do I need to attack with invasive testing to try and figure that out? What I can tell you is that I can probably decrease that 1/3, or actually no, I can decrease that 1/3 by applying appropriate prevention to the diabetic. And that appropriate prevention, like you talked about, is a statin, for sure, and then good blood pressure medicine as well. The other thing is, how do I differentiate moderate from high? And then the other thing I need to do is figure out the cost of assessing risk, There's monetary cost. We've already talked about that a little bit. Psychologic cost, oh my God, you just told me I'm going to die, or that I'm at risk for dying. And no cardiac test we do is without potential harm. Including a stress test. Now, I'm not going to kill people with a stress test, but if it's positive, I'm going to lead to a cath. If I'm going to do a cath, there's a 1 in 100 chance risk you're going to bleed from the cath, a 4 in 1,000 risk you're going to have something bad happen from the cath. And then if I'm going to go on and do a bypass surgery, then you're looking at a 1% chance of having a problem to a 10% chance, depending on who it is I'm operating on. So you kind of look at the upfront cost before you move forward.
So you're telling us, even when we're debating screening patients, make sure you have the whole conversation with the patient before you...
Make sure you have it with yourself in your head.
With yourself first,
Then with the patient. Because I think what we've learned probably in the pre-op literature, and probably with a paper called CARP, better than anything else, is that if you pre-op evaluate people at risk, what they have found is that fixing the risk led to as many deaths and as many problems as just going through the original operation. So if you take that analogy and apply it to the asymptomatic patient, you're going to hurt as many people evaluating them as you are people just letting them go. If you put them on good medical therapy, there's absolutely no doubt about that. So that's kind of how I do it. And the question is how do you kind of refine that a little bit to say, well, this guy was an extraordinary risk, and they're going to be the early dying person in the medical therapy arm. They would probably benefit from invasive. How do I pick those people out? The key there, I think, is what is their exercise tolerance? What is their metabolic reserve? And the key there is how much can you do, and how much do you do, and do you have any real symptoms from it? And you got to be extraordinarily persistent in asking questions about that.
At every visit, to see if there's been a change sometimes.
And the key is the change. Has there been a change in the last 6 months? If I've always been this way because I've just been lazy, that's fine. And what you find in a lot of people is, well, I just don't go up the stairs anymore. Why? Well, I don't like to. Why? Well, I just kind of do get short of breath going up. So, and what you find is subtle symptoms by continuing to be persistent about asking. The most important thing to ask is, do you still mow the lawn? Do you still walk up the stairs? Can you walk up the stairs with a basket of something? Or a set of groceries. If they're changing simple things in their life like that, they're likely changing them to avoid things, especially true in older women.
Okay.
Okay.
Who may have relatively not standard symptoms of cardiovascular disease, as we've been taught for years.
And then the last issue is what's the benefit? And it's not clear what the benefit is anymore because study populations who have been evaluated have found that bypass surgery is not necessarily going to prolong life anymore. Angioplasty does not prolong life. What both do is improve symptoms. But we have an asymptomatic individual.
Right.
So it's hard to make people feel better when they don't have any symptoms to start with.
That's right.
Unless you're persistent in trying to bring out the symptoms.
Okay. Mike, I got tricked a couple times where I've had patients who have come to me with diabetes who want to change their exercise level. They want to increase it dramatically. I'm respectful of the length of time that they've had diabetes, and I guess I query whether, based on what you've just said, should those patients be screened at all?
Yes. So that's the kind of patient I would screen. So the people who come to me or the people I manage chronically who I typically screen are the first individual I'll see because they want to change what their lifestyle is.
Okay.
And the individual who suddenly wants to go to Tibet or wants to go hiking in Colorado.
Right.
They're 55 years old, 65 years old. They now want to go on this big vacation and do something, and they haven't done anything like that in a long time.
Okay.
Those are the individuals you need to screen because suddenly that's just like a preoperative consult.
Okay.
Suddenly they're going to be stressed, and you want to make sure they can handle that stress without a problem.
That's an extraordinarily good point.
Okay. And so it's no different than a pre-op consult, and that's the way I look at it, and those are the individuals I screen. Now, individuals who have been in my clinic for years, I've been treating them, I very rarely prophylactically stress test them.
Okay.
Okay. And the reason is because if I'm taking a good history and I know what they're doing regularly in their life, and they're not going to do anything extraordinary, no reason to.
Okay. Very good.
I do tell them if they plan on something extraordinary, come see me.
You're going to run the marathon, tell you in advance. Okay.
Again, this is where in the cardiovascular questions for categorizing people, fitness is so important. And the key questions you want to ask are, how far do you walk and how fast?
Right.
Do you do regular exercise? And have you had any recent changes? Okay. And then do you have hypertension? What's your cholesterol? What's your family history? All the other usual things we do. But really spending a fair amount of time on figuring out what people do as a baseline is incredibly important. Physical exam is important because you want to know what their baseline disease is. Bruits mean they have baseline disease. A stiff heart means they have baseline disease. Edema means they have baseline disease. No pulses means they have baseline disease.
Okay.
So all of those things really do help. You got to do more than just put the stethoscope across the shirt.
Okay.
Okay.
And then you're going to tell us once we find these things on exam if we should do further testing?
If you find a burden of disease, then absolutely have to initiate prevention, which is hypertension and hyperlipidemic management, and then you want to consider risk stratifying the patient in an objective manner.
Okay.
And risk stratification in an objective manner means a stress test. Okay. Ideally, a walking stress test. If they can't do a walking stress test because they can't walk, then the question is how much are they going to stress themselves again? Do they really need that? Am I going to make their life better by opening Pandora's box? Okay. If they have a large burden of disease, I know I'm going to put them on medical therapy. I know medical therapy is as good as doing intervention. I'm not sure I need to do it. Okay.
That's good.
So the costs, again, come down to the following. There's two big studies that you should be familiar with. The DIAD study, DIAD, and Berry 2. And what both showed is that screening tests did not affect the mortality of the population in asymptomatic populations.
Two studies that showed that.
One showing bypass surgery and intervention, and the other one showing a nuclear stress test did not affect the ability. So you took half the population, stress tested, and the other half medically treated with good medical therapy in both areas. You could not affect the mortality of the population or the morbidity by doing that. And that's this study here. It was a good study. It was a large study as stated here, okay? It had a relatively lower event rate than anticipated, so the power of the study is a little bit less than anticipated.
All right.
But my bet is if you did a bigger study with better power, you're not going to see anything different.
Okay.
Because there just was no signal at all here.
And this was the one compared to imaging?
This was the imaging study. This was the imaging study.
So these are two studies that would be useful to discuss with your patients when you're offering the idea that you're just going to medically.
Very interesting in this study, when you did have a positive stress test, okay, you in fact were found to have a higher level of disease. No problem with that. Surprise? No, not surprised. However, finding the higher level of disease did not lead to saving lives. And that's the positive predictive value. Okay. So the key is just because you uncovered disease, which you knew was there anyway, doesn't mean you're going to make people live longer.
Okay. So in that sentence it says the positive predictive value was low at 12%.
Correct, which means that the number of individuals that you can actually affect the longevity of their life is going to be quite low in trying to do this. And that's what it comes down to. That's the positive predictive value.
Okay.
How useful is the actual end outcome of the test?
Okay.
And the answer is, even though the test is positive, it isn't great.
Okay.
So it isn't like, I would say, very interestingly, the positive predictive value of a CRP in a diabetic is a lot better.
C-reactive protein.
C-reactive protein is a lot better, because if your C-reactive protein remains high and you're on a low-dose statin, recent studies would show a high-dose statin in that kind of population, which is asymptomatic, with pre-diabetes at least, the Jupiter study, demonstrated a mortality benefit in treating with a potent statin. Okay. So getting your risk factors down to acceptable levels, including probably now inflammation as a risk factor, really is beneficial.
Okay.
That's Barry 2D. I just recommend you read the paper.
Okay.
How do you apply the goal? I think the way you apply the goal now is you get people down to what are goal-based strategies. The newest studies that are coming out are really trying to define what are the goals, which are expert opinion right now, for the most part, are actually correct.
Okay.
And the study that just came out that questions that, of course, and great timing here is Accord, which basically stated, do I take you to a blood pressure of 140 or 120? Okay. Which is better? And everybody thought that 120 was going to be better, and in fact, there was no difference between 120 and 140.
So now, just for our...
Treating for 5 years.
Okay, there we go.
Okay, for a relatively short period of time in the overall spectrum of a long-term diabetic trial. Okay, how much harm was there? There unfortunately was a little bit of harm to using more medications too. So the take on it is that 134, which is where they got in the trial, is probably adequate. Okay, you definitely want to be less than 140 without a doubt. And do you need to push it further to get down to 120? Probably not a lot of benefit.
Okay.
Okay.
So if we've got patients, just for our listeners, because we've all been working on these blood pressures now, because remember the American Diabetes Association said blood pressure is more important than blood sugar. Correct. If we're in the 130 range and certainly less than 140 on our current medications, and you mentioned on this slide that you like the ACE inhibitors, we're doing fine. We don't need to push to 120. There's
don't
no
need to
data
push to 120. In fact, there's no data that it helps more, and there is data that the higher number of medications together actually are a little bit of a detriment. Not much, but a little. Okay. Now, if you happen to get them down to 120, do you need to back off? No.
Good. Okay, that's important for our listeners.
Yeah. Okay. Hyperlipidemia, need to be on a statin. The CARDS trial was the seminal trial here, asymptomatic, huge benefit, no mortality benefit in that trial. Why? Because they stopped the trial too early. Okay. Why did they stop it early? Because there was too much morbidity benefit. Okay. There was a mortality benefit in the Jupiter trial, which was a pre-diabetic population primarily. It was all metabolic syndrome, very high dose, very high percentage of the population with metabolic syndrome. Elevated CRP is what was the target for treating in that trial, not LDL.
All right.
And however, if I do the thinking back and forth, there's no doubt that there's mortality benefit to putting diabetics on an ACE inhibitor. Okay.
Or a lipid-lowering
agent. I'm sorry, on a lipid-lowering agent. Thank you very much. Yeah. Which statin? Doesn't matter.
That's what I was going to ask. Because those two trials use different drugs. So.
Doesn't matter.
Okay.
What you want, in my opinion, if you're diabetic, is you want your LDL below 100 milligrams per deciliter, and ideally at 70.
If we're between 70 and 100, do you keep pushing?
If the CRP is up, yes. If the CRP is down, no.
So you've said CRP several times, Mike, so you're suggesting to us that we might want to evaluate CRP?
I think at this point the next guidelines are going to show that CRP is important. I think the Jupiter trial is a seminal trial in that. And I think if you don't have both CRP down and LDL down, your risk isn't fully decreased as much as you can get it.
Good.
Now, CRP is that inflammation part of the blister I talked about earlier, right?
Right.
So CRP just looks at how much inflammation you have. By lowering the inflammation with a statin, you lower risk. Okay? So the inflammation is the stability of the plaque. LDL and hypertension are the building of the plaque. You want, at the end of the day, no more building the plaque, and you want them stable. So you need both things treated.
And just to clarify for our audience, because this is a mistake a lot of folks sometimes make, is the C-peptide is not the same as the C-reactive peptide.
No.
The C-peptide.
HSCRP, high sensitivity C-reactive protein is what you want. The C-peptide has to do, of course, with insulin.
Right.
And those are different things.
Different things.
Finally, what I want to talk about is the risk of a statin. Okay. Many people will come to you and tell you that they've read the internet, that the statin is going to destroy their liver, the statin is going to kill their muscles, and they're going to die from the statin. you are 500 times more likely to die from the aspirin you take than the statin, and almost everybody will take their aspirin without a problem.
Right.
You're in North Carolina, you are 4 times more likely to be hit by lightning than to die from a statin. Nobody's liver has ever been destroyed by a statin alone, ever. And that's in billions of prescriptions, to be honest. Okay? And the likelihood of developing a myopathy, rhabdomyolysis, when you've been appropriately evaluated with a statin is on the order of 1 in 100,000 to 1 in a million. So it's also very, very low. And the key is when you start people on them, tell them if they have muscle aches or pains when this comes on, stop it.
Right.
It's people who persist through this that get trouble with the rhabdo, not people who get it first right away.
Absolutely right.
And so then the statins are very, very low risk. Okay. They're probably lower risk than Tylenol. Okay. Inflammation I just talked about. Again, what this means is you're going to have to push more people to higher doses of statin. Okay. Those are safe. Do realize you'll get more muscle ache that comes out of that, and if you run into the muscle ache, then you back off or try a different statin.
This slide is a pearl for many of our listeners. I'm not sure that we've been very clear on using the HSCRP for asymptomatic folks with diabetes.
Aspirin has now become extremely controversial in what to do.
It has been.
The big issue with aspirin is because of its detriment that I talked about.
Right.
The risk of bleeding of about 1 in 10,000 to 5 in 10,000 in the head, a risk of bleeding from a GI tract of about 1 in 100 or more. It actually is the most dangerous drug we give. It is also the most that's easily gotten and cheap. Right. So it's given out like candy.
Right. It is.
Like candy, it's not good for you.
Yeah, that's right. Good point.
Okay.
I'm full circle on food here. So
I still would put diabetics on an aspirin at 81 a day at this point in time.
At what age?
At an age over 55 for men, and over 65 for women. Okay.
We have younger patients with diabetes who really resist starting to take the aspirin early age.
So I would say the following, though. If they refuse to take a statin and don't have good blood pressure, then I would put them on the aspirin because there'll be benefit. If they have good blood pressure, good statin, there won't. There's competing risk here. So all of the early aspirin data that said aspirin was good was done in people not on statins, not on good blood pressure control. And aspirin then is incredibly beneficial. Why? Because you rupture plaque all the time and it prevents your heart attack.
Right.
Stop the plaque rupture by putting good prevention, and all of a sudden all you see is the detrimental effect and not the beneficial effect of the aspirin.
Excellent.
So if you can't take certain preventions, then I would add the aspirin back.
Gotcha.
That's, I think, the key with aspirin.
Okay.
How do I apply the goal, and what's the summary? I think that prevention with medical therapies for hypertension and hyperlipidemia is incredibly low risk and incredibly beneficial and should be done in every diabetic. Okay? Monitoring needs to be mostly metabolic and lifestyle and not so much invasive and non-invasive testing. Invasive and non-invasive testing needs to be reserved for people who start to develop symptoms or have a change. That's where you want to go with that. Okay? And what you really want to do is engage the patient in this, engage the patient in the ability to stop the progression of their disease. Okay? And yeah, they're diabetic, but that doesn't mean that they need to do anything other than take a couple of pills a day, and the pills are like vitamins. Nature or whatever dealt them a bad hand. This is how they make their hand be a good hand. Okay? These are the hole cards they can draw in poker, if you want to look at it that way. And it really helps them. Without a lot of cost and without a lot of harm.
Excellent. Mike, this has been an extremely useful discussion, and I know that our listeners will find extreme application for a lot of their patients in the clinic. We see so many folks with diabetes these days. Our guest faculty today has been Mike Blasing, one of my colleagues here at Duke. Mike, thanks again for joining us and for such a great conversation.
Thank you, Diana. Thank you.
Until next time, then, from all of us here at Duke, this is Diana McNeill saying thanks for joining us and take care.